Good morning, good noon. Welcome to the Great Talks. My name is Joseph Zhongchen Xu, the director of the Cardiovascular Center in Far Eastern Memorial Hospital. And thank you for joining this scientific session, including the audience online. The session is focusing on the contemporary and the future directions in coronary care. And I would like to thank our supporters, the SMT company from Ireland, and also the local distributor, 60公司. And I think today we have the two excellent talks. I would like to introduce the first speaker, Professor Yoshinobu Onuma. Professor Onuma is the professor of interventional cardiology at the National University of Ireland, Galway, and also the medical director of the Coronary Research Center and have core lab for coronary imaging. And today his topic is a brief of coronary revascularization, what I see in 2040. And thank you, Professor Onuma, being with us. And please share with your slides when you are ready. Thank you.
Thank you for the kind introduction. So, my talk is about a brief of coronary revascularization, and this is based on the recent publication in the European Heart Journal. But I would like to also thank our Taiwanese fellows who help us to prepare this talk, Hao-Wei Li. We have a long tradition of fellows from the Taiwan as well, Chun-Ching Chan, and also the John Tsai, and Hao-Wei Li, Fei Ran, and now we have also a team from the Taiwan working in our core lab. So this is about 2040, 15 or 14 years from now. Of course, it is, life can only be understood backwards, but it must be lived forwards. That's the word of the Soren Kierkegaard. So maybe some of the prediction is true, and some of them are not to be true. But I think based on the current evidence and perspectives, we try to describe a long-term perspective of coronary revascularization. So in this paper, we have a 15-point somewhat to predict the future or provide some long-term perspective on the coronary revascularization in the next 10, 15 years. So the first point is that imagenomics. Is it going to be the new discipline in the cardiology? So what is going to impact coronary revascularization in the next decade? First of all, there will be a lot of omics, genomics, lipidomics, proteomics, and polygenic clustering, and AI will help to detect CAD, predict prognosis, and personalize treatment. And it will be combined with non-invasive imaging. The so-called imagomics will help also to document coronary artery disease anatomically and functionally, and to allow decision-making between conventional revascularization, PCI, CABG, and also there will be some pharmacological revascularization through the plaque regulation and improvement of coronary physiology, FFRCT, for example. It was shown in the EVAPORATE study that the icosapent ethyl can really improve the physiology of the coronary artery by lowering the LDL cholesterol. Also, there is a symptomatic biological gene editing will be available, siRNA against LP small a, PCSK9, monoclonal antibody against PCSK9, IL-1 alpha or IL-6 or the inflammatory molecules. gene editing against PCSK9 and others. Also, the obesity drugs such as semaglutide or tirzepatide will boost the pharmacological revascularization. Therefore, the rate of the mechanical revascularization may diminish, at least in the young patient. This is just one example case report from the reported last year, trying to show the pharmacological revascularization by the rosuvastatin and the ezetimibe. So in this case, the patient was very young, 51 years old male. LDL cholesterol before treatment was 214 milligram per deciliter, and you can really clearly see the plaque in the distal left main, which looks like a very low attenuated plaque with some calcification in the CT. So the patient was treated with the rosuvastatin, ezetimibe, the LDL cholesterol going down to the 85 milligram per deciliter, and eventually after the administration of PCSK9 inhibitor evolocumab, then the LDL cholesterol is going down 21 milligram per deciliter at 6 months, 12 months follow-up 14 milligram, and 18 months follow-up, the LDL cholesterol was as low as 10 milligram per deciliter, and you can really see the improvement of the coronary physiology as assessed by the FFRCT. Initially, the FFRCT distally was more or less positive 0.77, which is improved up to 0.80 at 1 year follow-up and 0.84 at 18 months follow-up. So it's just to illustrate that it is possible to do the pharmacological revascularization. What about the device we are using to devascularize the coronary arteries? So these are the trend of recent trend in the coronary revascularization. Over the next 10 years, we will see a decrease of the global PCI and CABG market. The trend will continue over the next 16 years. But the other point is that for the PCI, some of the predictions shows that the increase of the drug-coated balloon in addition to the drug-eluting stent, and maybe in the 10 years from now, the DCB might be also used more frequently than now. Some of the market predictions show that 40% DCB and 60% drug-eluting stent. And also the population will change over the time, and the age pyramid will have major various and evolving impact on the revascularization in the different regions of the world. At least in Europe, there will be a more elderly people in this next decades. So the young patient who has a soft focal with the lipidic content will be treated through the plaque regulation obtained with the anti-atherogenic agent. And maybe there is a little bit of the decrease of the mechanical revascularization in one young patient. However, in the elderly patient with the calcium, that will be the very difficult to treat with the mechanical revascularization. Therefore, we need to have a cutting balloon, a scoring balloon, non-compliant balloon, rotational atherectomy, laser, or lithotripsy. So mechanical revascularization in the elderly patient will remain predominant over the time. These are the armamentarium of the coronary PCI, and the metal-less era has started, and in the armamentarium will be a blend of the various technology strategies. So you could also see that last TCT there is a positive outcome of the solution de novo trial. Just to exemplify that DCB is still showing the good results. So future will be some sort of blended therapy by combining drug-eluting stent with the various devices such as drug-coated balloon or the bioresorbable scaffold. Especially the magnesium is very promising. There will be also another orbital atherectomy, laser rotational atherectomy, lithotripsy, and also the biodegradable half metal, half biodegradable device such as the Dynam-X. Also, there's a bioresorbable ion. There is a bioresorbable scaffold with a fibrillated supramolecule or polylactide, etc. So kind of the sky is the limit, and there will be a lot of a combination of blended of the new technologies in addition to the drug-eluting stent. What about the angina, ischemia, and plaque burden? I think over the next 15 years, there will be the debate evolving over the vulnerable patient, plaque, and also the systematic and pharmacological or local device treatment of such vulnerable plaque. And also the ongoing discussion is that is the angina is important or the angina be perceived as less detrimental in terms of prognosis. Look at the ischemia trial, etc. And maybe those angina will be the less aggressively treated by the mechanical revascularization. There's also some people say that the bad physiology should be perceived as more detrimental in terms of prognosis, but be treated more aggressively by the either pharmacological or mechanical revascularization. But ultimately, there's also the plaque burden and high-risk lesion becoming the more predominant factor in the vital prognosis. So it's kind of a new vision of the CADRAS consensus and also shown by some of the Emerald studies, AI, QC, PHA. So you can also see that in the Emerald 1, which is the study from the Professor Ko from the South Korea, showing that the predictive factor for the future acute coronary syndrome using the coronary CT, including FFRCT, diameter stenosis, or the shear stresses. And there will be a more sophisticated way to predict the future coronary event using the non-invasive imaging using the coronary CT angiography. And there's also the 20 years of the trial for the vulnerable plaque, like a secret, FIBA, prospect, prediction, etc. And the recent one is PREVENT trial from the South Korea, showing some benefit of preemptive stenting, but this, I think still the predictability of the vulnerable plaque is somewhat not perfect. So this will be pursued probably with non-invasive imaging with the CT. So this is an example of mixed calcified plaque in chronic coronary syndrome, necrotic core, and CT will be really useful to also look at the vulnerability of the plaque. What about the how to assess the coronary high-risk lesions? So as mentioned, Emerald 1 and Emerald 2 both show that using the technology of the CT, using not only the plaque, but also the hemodynamics such as the wall shear stress or the FFRCT or delta FFRCT, total myocardial blood flow, etc., then they could really, using the AI, come up with the 5 features for the identification of the ACS culprit lesion, which was a delta FFRCT plaque burden, total plaque volume, low attenuation plaque volume, and average percent total myocardial blood flow, which is quite novel parameters. So in the future, we think that there will be a lot of genomics and imagomics, but also AI will help us to use such a new information to digest, and we can have a more quality time with the patient and also give back a more human face to medicine for the well-being of the patients. These are the examples of machine learning algorithm for the probabilistic statistics, and there's a growing number of the algorithms. Most of the time we use either lasso regression or the gradient boost or the random forest, etc. But there's a growing number of the machine learning which also will enable us to be the more precise on the risk prediction of the individual patient. This is a statistical approach, but using the machine learnings. There will be also the next generation of the cardiac MRI, and that will become more and more like CT, while the next generation CT will become more and more like MRI. So, and we believe that those non-invasive imaging will be predominant modality of diagnosis of the coronary artery disease in the future. So this is just an example of the non-invasive MRI and hemodynamics. So if we could really look at the hemodynamics, maybe there's no need for the invasive hemodynamics measurement, but we can use this sophisticated non-invasive imaging to simulate the pressure, and also we could really see the physiology or the rheology of the blood flow using such high resolution images. What about antiplatelet therapy, P2Y12? There might be the new way to think platelet inhibition. We will have a metallic and polymeric device semi-covalently coated by the biomimetic CD31 coating, which is a transformophilic for endothelial cells and transformophobic for the platelet and the leukocyte. So it's kind of the a peptide, which is very different from the CD34 previously used for the capturing the EPC coating. It's just for the different CD31 molecules, and by putting these peptides, this technology provides a camouflage layer that mimics the healthy endotheliums and bluffing the platelet and leukocytes, so that will not create the inflammation or the thrombotic reaction by putting these foreign materials if it is covered by the CD31. So it is still work ongoing. Preclinical work shows that complete industrialization of the device in 7 days without the presence of the thrombus, which was led by the Professor Caliguri from France. So if this CD31 coated technology is coming to the clinical practice, there's potentially no need for the P2Y12 for the device therapy. Another perspective is this thrombolysis in acute myocardial infarction. Of course, the thrombolysis was introduced in the 1979, 80s, but there is maybe the possibility to come back of this thrombolysis, but with the nanotechnology. So the cluster of the nanospheres sensitive to low shear stress, triggering the release of nanospheres loaded with the TPA with the much lower dose of TPA we are using currently. So this nanotechnology is shear activated. So actually the low shear stress, high shear stress point will be really targeted. So it will really attach to this total or subtotal occlusion. And this new technology was reported some time ago in the science. So there might be the progress in this field of the thrombolysis using the nanotechnology. CCTA will be really the major modality of the imaging. So you could see that there is also the pretest probability of the ESC, and CT could work as a one-stop shop. Already in the 2024, 2025, we could use it as a clinical tool. So what is the advantage of the CT? So CT could really look into the stenosis detection. You can look at the ejection fraction, wall motion abnormality could be assessed very precisely by the cardiac CT. CT can provide a physiology, FFR CT. You can look at the hologram and look at the measure the graft length, for example. Also, we could assess the microvascular circulation and myocardium at risk by looking at the myocardium beyond the coronary artery. And each side branches could really see that how much myocardium at risk for the treatment of the side branch or the major left main lesions. We can also use the plaque assessment by the CT. You could look at the tissue composition according to the Hansfield unit. We also reported the one kind of the new phenotype of the coronary artery, which is called donut, because the very low attenuation plaque, which is probably lipid, is really the covered by the ring of the calcium. So this is a new phenotype, which is very difficult to see with the intravascular imaging because IVAS could not see the deep part or beyond the calcium, and the OCT could not see after the lipid. So this type of the plaque is probably not detectable by the conventional intravascular imaging, but photon counting CT for the first time could describe this donut kind of the plaque phenotype. We also have a perivascular fat, which is related to the long-term mortality, and that is related to the inflammation around the coronary arteries. we can already use the syntax score and using the clinical factors such as age or creatinine clearance, ejection fraction, etc., and predict the MACE and death 5 years and 10 years after the PCL CABG, and this could be used for the selection of the mode of the revascularization. So currently already we can use the CT to move directly to the cath lab, to move the patient directly to the cath lab or the operating room for the bypass surgery or the primary prevention. But this is a state of the art in this 2025 or 2026, but that will be routine in 2040. So there will be less and less role for the invasive imaging for the diagnostic angiography. This is just one example of a planning of the left main PCI based on the CT. So in this case, patient had a CT. We know the syntax score. The part-in discussion was held solely based on the CT. And we decided to use the 3.0 catheter based on the diameter of the aortic and aortic root, and also look at the calcified plaque. There is a severe calcification in distal left main, which is more than 180 or 270 degrees, so that we decided to use upfront lithotripsy for the treatment. And there is also the optimal projection during the angiography, which projection would be the best for the described left main or the ostium, and that could be predicted by the CT. So we could use during the procedure these best projections predicted by the CT imaging. Also, the PCI could be planned according to the predicted FFR CT. So in this case, if you treat the CT, we know that this patient will have a good FFR. So there's an intermediate lesion in the mid-LAD, but we didn't stent it. So these are that kind of the planning could be done using the CT already. And also the patient directly going to the bypass surgery, the feasibility of the referring the patient directly to the surgery only solely based on CT was demonstrated last year. It was called a fast track CABG trial, and we could really refer the patient to the surgery directly after the CT. So in 111 patients, the feasibility of operation solely based on the CT was 99.1% feasible, and safety assessment shows that graft patency rate was 92.6%. So in 2040, conventional coronary angiography prior to CABG will no longer be performed, and with the sole guidance of the new generation of CT angiography, decision-making in favor of surgery or the PCI or pharmacological study will be made routinely by the heart team, and CT will be a game changer, and also will be the gatekeeper of the mechanical revascularization or the pharmacological revascularization. So what about the virtual reality? Will it be a part of our routine? This is just a example of a hologram of the CT, OCT during the procedure. You could really acquire the OCT and look at the dissection after the drug-coated balloon. You can really appreciate that the dissection is really the three-dimensional structure and really longitudinally expanded. And during the procedure, without touching the screen by just a gesture, you could really manipulate the three-dimensional images, and that will be probably useful of some of the procedures, and those type of the 3D visualization during the procedure will be feasible in the near future. So what about radiation? It is kind of the concern for the interventional cardiologist, and there is also the development of the fiber optical real shape, which is a light instead of X-ray to steer the guide wires. So this is just new technologies, and without radiation, it's just based on the light, and you can really detects the shape of wire or catheter itself. So you can really see that this is not angiography, it's just a fiber catheter itself could really show the three-dimensional configuration of this catheter. So without using the X-ray, you can really see that where the catheter is and where the wire is. So in the future, just with co-registering the one shot of the fluoroscopy, we can really do the procedures without repeating the fluoroscopy. That's maybe the feasible in the near future. What about robotics? So robotics used to be used in the cath lab. For example, this technology of magnetic camera was used already in the early 2000s to steer the wire. It was a magnetic field which can bend the tip of the wire, and we used to use it to do the complex procedure like in the bifurcations, but still I think robotic field is emerging and developing. So there was first-in-man experience of robotic assisted transcatheter edge-to-edge repair with pure echo guidance, and probably we should also follow the example of surgeons. This is the heart transplantation based on the robotics. And so in the end, that this is really amazing that heart transplantation was done by the robotics, and it's only with the small intercostal incision of 7 centimeters. So you can really see that this smaller incision, you can put this new heart. Yeah. So what about the virtual reality? So as demonstrated, we could use the CT for the virtual heart team discussion. And for example, in this case, we also measure the length of the bypass graft needed for this patient. So this patient need a bypass graft, but we want to measure how long the graft should be, or the so we could really measure on the hologram what will be the future length of the graft is, and we could provide that information to the surgeon, so the surgeon knows that we need to have multiple arteries to harvest. It's one of the example from the Professor John Puskas from New York in one of the case of fistula cavity trial. So the patient was fully arterialized revascularization, and it was also performed off pump. So you could see that the surgeons really harvested multiple arteries, not only the rima and the lima, but also harvested the radial artery, and that was connected to the rima and to this from the right coronary artery to this circumflex, and also lima was connected to the radial arteries and going to the circumflex, and also a jump graft was placed in the diagonal and LAD. So it was really a great case of the 5 arterial anastomosis, and that could be done solely based on the CT information derived from the CT angiography. So, and patency was great, and this was the 3D image of the follow-up at 30 days. So that type of the virtual heart-thing discussion based on the CT, and also the planning of the surgery based on the CT is feasible and will be the the normal clinical practice in the 2040. And of course, the surgeon has the also the development in technology and the techniques, and that will be also very important modality of revascularization in the future as well. So you could see that there's some progressed technologies using the supramolecules, biodegradation is also kind of the biodegradable graft is developed with some metallic component. And in this work of the Celtis, we have seen that in a sheep model, there is a good patency, and in a first-in-man study that in this case, a patient received this polymeric graft, which is in the placement of the saphenous vein graft, and it shows that quite good patency, at least in this case. So there is also the advancement in the technologies, and also there is a development of the xenotransplantation, or also the artificial heart is developed, like a Karmat heart. So the surgeon will have a lot of new technologies as well, and they will be also live and kicking in 2040. Also, after the introduction of the regeneration study therapy, and this is the dream of the biofabrication using the heart, the helical structure, and using this spinning technology of the polymer to make this, to mimic the helical structure of the heart. And this is the also ongoing effort to develop the new heart. What about the photon counting? So photon counting CT detector is already in place in some of the places in Europe, and also I heard that in Taiwan you will have soon the photon counting technologies. Photon counting is quite different from the conventional CT in the sense that they can have a direct conversion of photon to the electrical signal. So it's in a normal conventional CT, the energy integrating detector is used to by indirect conversion to the electrical signal, but the photon counting is a quite different technology which enables us to see the coronary arteries with a great precision and great resolution. So you can really see the quality of the image is much better with the photon counting. This is a conventional CT. Mid is a high resolution CT. High resolution CT, you can see the calcium better, but you don't see the non-calcified plaque well. But with the photon counting, you can clearly see the differentiation between the calcium and the non-calcified plaque, and it is really the kind of the step forward for the CT technology. The left side is photon counting. In the stented segment, you can really see the one by one, you can actually count the number of the struts. So it's like IVAS or the OCT. Conventional CT will not really show the differentiation of the strut, but with the photon counting, really we can appreciate the stent implanted sometime before this imaging, and in this case, you can really see the metallic carina of bifurcation stenting. This is another example of see the clear delineation of the lumen, and you can also clearly look at the plaque as well. So it's a quantification plaque will be more easily done by this photon counting CT. This is an example of also the distribution of the calcium within the plaque. And this is an example of IVAS. So for IVAS, one of the limitations is shadow created by the calcium. So if there's a multiple calcium on IVAS, it's not really visible because it was already covered by the shadow of calcium, which is positioned close to the lumen. But with the CT, you can really further see this different type of the plaques and distribution of calcium. This is another example of photon counting of CTO lesion. You can really see that what kind of the lesion it is. It is not so much calcified, so probably the revascularization will be not so too difficult because it's all the low attenuation, maybe thrombotic one, and distal cap is also soft without calcification. This is another example of donut image. We just talk about that in the previous slide, but just to show that this new phenotype of donuts, which is the calcium surrounding this lipid core, is found by the photon counting CT. This is very difficult to detect by intravascular imaging because for the IVUS, the shadow created by the calcium very close to the lumen will not show the deep calcium. For the nearest lipid could be detected, but you can still not really able to see the surrounding calcium. So this is only the phenotype of the coronary artery disease, which could be detected only by the CT, especially the photon counting. So the last part is the helical phase contrast tomography, and this is one of the recent publications show the feasibility of this hierarchical phase contrast tomography. So this is an 87 years old lady, and with this technology, you can really see the the fat surrounding the coronary arteries, and you can also see that how much distance you have between the epicardial arteries and the myocardium. So actually, the coronary artery was somewhat lifted from the real myocardium, and you can imagine that microcirculation is really also addressed in this space, so that there's a really the function of the pericardium fat on this microcirculation, because the microcirculation also should penetrate this lipid. So it was really the great already discovery with this kind of imaging. It is really the high resolution up to the 2 micron, and you can really cut the heart as you want. So you can really change the angle, you can change the cutting plane, and you can also see the myocardium as well, and also you can really see the valve, etc. So maybe just show one time. So this lady has previous myocardial infarction, so you can really see that after this coronary presentation, cutting of the myocardium, and this is just rotation. You can really see how the artery and vein are intertwined in this anatomy. It's like anatomy, but with a very high resolution. Yeah, so you could see here in the inferior wall, you could see the black part of this myocardium here. So this part was infarcted previously. So you can really assess the myocardium as well as coronary arteries. It is a voxel of 2.26 microns. So it's like a microscopic view, but together with the CT kind of the information. And we can also look at the artery and veins and stented LAD. It's kind of the resolution of the histology. It looks like a micro OCT, which was reported by Gary Tani some time ago. And you can, with the micro optical coherence tomography, you could see the cholesterol crystals, but based on this type of the new technology of the CT, you could also see that kind of the details with the resolution of the 2 micron. So, but I think we might leave it mislead the audience, because for this last topic of hierarchical CT, it's a post-mortem heart, and it must be fixed in a glutaraldehyde, and it's only available in the limited institute, because you need impinging photon should be accelerated linearly by the synchrotron. So if you don't have a synchrotron, we cannot do this type of the imaging, but maybe in the 15 years from now, this type of technology might be available, maybe in the clinically. So instead of rotating beam, for the time being, to do this type of imaging, we need to rotate the heart, and that was done in the ESRF in Grenoble. So we just trying to glimpse into the future and time to conclude. And so Professor Sirai's quote usually tell the fellows, and that's one of the most frequently quoted propositions of the PhD thesis: if the future is unrealistic, fortunately it will remain the future. If the future is realistic, sadly enough, it will soon become the past. Thank you for attention, and I'd like to also thank the organizers for this kind of invitation. And my apologies not physically present there because of my personal circumstances, but it was very good to talk to you, and I want to be there to see the Far Eastern Memorial Hospital. So I hope that you enjoy the talk and also enjoy the rest of the Congress. Thank you.
Thank you, Professor Onuma. Very excellent talk. And I have been to Ireland last November, and I have met with Dr. Lee. Yeah, and thank you for taking care for him. And I think it's too much information at one session. And any question? One or two, because the time constraint. And luckily, we will have the photon counting CT this year in our institute, and we are looking forward to have the opportunity to cooperate with the Heart Flow company. But I'm not sure that the Heart Flow company will cooperate with us. So maybe we can ask for the help of the Professor Onuma. Okay, so thanks again. And next, I would like to introduce the next speaker, Professor Simone Biscaglia. He is the senior interventional cardiologist at Ferrara University Hospital, and he's also the principal investigator of the FIRE trial. That is the randomized control trial that comparing the physiology-guided complete revascularization versus culprit-only revascularization strategy, and it has been published in the New England Journal of Medicine. Today, it's our honor to have him here and to have a talk that entitled MI Treatment in Europe, Guideline versus Daily Practice. The floor is yours. Thank you.
Thank you. Thank you so much, Joseph. So, first of all, it's a pleasure to be here with you today. I loved being here. I arrived yesterday, but I already love your country, so thank you. And so we will be back to 2026, so it will be a simpler talk rather if compared to the one by Yoshi. So the idea would be just to follow the journey of a patient with MI from the very beginning, so from the presentation at the hospital to the follow-up in light of the European guidelines. And what I would like is just to discuss with you which is the best way to treat those patients according to our experiences. So it's more an exchange rather than a lecture. So, but if we start from the beginning, so patient coming with an MI, the European guidelines, what they suggest is to perform a primary PCI as soon as possible. So as you see, the class indication is 1, so the most relevant indication for basically the management of the patient in the acute setting. So as soon as you deal with the patient with MI, the first thing you should perform is an EKG, and obviously send the EKG for transmission. And then if you confirm a diagnosis of ST segment elevation MI, send the patient to the cath lab. That's the first point of any guidelines on MI. So how is it possible in my daily practice? Where I live in Italy. Ferrara is in the north center part of Italy, and you see it's a big area, but there are few people in my province. We are the only PCI hospital of the province, so we have to take care of all the inhabitants of our area. And if I have to tell you how is the organization for myocardial infarction in my city, I think that there are some key aspects that enable us to perform actually what the guidelines say. So to perform the diagnosis and send the patient to the cath lab. Obviously, the first point is about location, because we have a big area but very flat and with good connection. So with the ambulance, it's very easy to go from one place to another. We don't have mountains, sea, or other, issues. And the second is the fact that we, as you can see, we are the hub center in the middle, and we have actually some spoke centers. These are the two biggest ones, sending patient to our center, and we are kind of in the middle, so it's kind of easy, for the people to transfer patient to our center. So the first point is about collaboration, because we have a very good collaboration with our spoke centers. And what we try to do is we have the EKG on each ambulance. So each ambulance has its own EKG and a transmitter for the CCU of the hub center. So all the EKG are sent to the hub center, and there is obviously the cardiologist at the CCU of the hub center confirming or not a diagnosis. If the diagnosis of STEMI is confirmed, then the patient is all sent directly to the cath lab. Okay, so this is in our opinion, the best way to, reduce the time that is lost, for between the diagnosis and the treatment. This is actually what we are doing a continuous registry in our patient with MI, and this is the data from the last year, and you can see that almost more than 60% of the patient are actually coming from the emergency service directly to the cath lab. So this is, I would say, a good percentage. Obviously, there are still some patients presenting to the ER, so without calling the 911 or the number for the emergency service. And this actually was translated into, I would say, good timing, because you see that the timing from the first medical contact to the balloon is around 60 minutes, so it's in line with what the guidelines say. And what is important, at least in our organization, is that in STEMI setting, sensibility is better than specificity. So it's okay if you, as in our case, you have around 10% of patients for which primary PCI is indicated that actually don't have occlusive disease, but it's better to have these 10% of patients performing, coronary artery angiography rather than having patient not performing coronary artery angiography but with STEMI. So it's actually good, even if you don't have 100% specificity. So the second point is to have a simple protocol, because if our colleagues going to the ambulance, as in this case, have to ask many questions to the patient, or have to think to different drugs, or do I have to perform, IV ZP2A3B inhibitor, or morphine, prasugrel, heparin, aspirin, ticagrelor? No, what we try to do is to keep it very, very simple, so it can be done in all the cases, and the focus is to send the patient to the cath lab as soon as possible and as fast as possible. This is in line with what the guideline says, because if you see, pre-treatment is not suggested by guidelines in terms of P2Y12 inhibitor. So the guidelines don't suggest to perform routine pre-treatment in STEMI patient with the second antiplatelet agent. So what we do is just to perform aspirin loading dose, 4,000 units of IV heparin, and send the patient to the cath lab. Simple, easy, fast. Why is that? Because as you know, there are studies in which we participated in the Atlantic trial, and we tried to demonstrate that pre-treatment with ticagrelor before primary PCI was effective, but the result was extremely negative, so there is no need to pre-treat patient before primary PCI. So now, if we move to the second part of the management of the patient, so primary PCI, I don't know how many of you here are interventional cardiologists, but I think that if I ask you what is the worst nightmare for you during primary PCI, I think that most of you will tell me no reflow is the worst that can happen. So what do the guidelines say about no reflow? As you know, no reflow is the absence of reperfusion despite the opening of the vessel. There are many different mechanisms because no reflow is a complex issue, because you have obviously the compressing of the vessel by the swollen myocyte. You have microemboli going from the plaque to the distal part of the vessel. You have red blood cell rouleau impairing the vessel and reducing the flow. You have edema, you have neutrophil plaques, you have the swelling of the endothelial cells. And so basically you have many reasons why you can have no reflow. And we have many studies trying to use drugs or interventions to reduce no reflow. And basically, as you see on the right part of the slide, we are not able still to understand how to treat no reflow. So if I have to tell you my experience, obviously the most important suggestion we can have about no reflow is to avoid the delay of primary PCI, because obviously no reflow is related to the length of the time from diagnosis to the treatment. Try to perform direct stenting if it's possible, not to go too high with the pressures of deployment and post-dilation during primary PCI. If you have high thrombus burden, try with the pharma to reduce the possibility to have a huge embolization of material. And obviously you can use also vasodilatory drug, but then they are mostly used in bailout, not as something you can use to reduce or not to start with no reflow. These are the medication you can use. You can use adenosine, you can use nitroprusside, epinephrine. It depends according to what you have in your institution. What do the guidelines say about no reflow? Basically nothing, because there is no solution for no reflow. They say that pre-treatment with GP2B3A is not recommended, so you cannot do it in all the cases. You may select some cases where you need it, but not as a routine treatment. But actually still we don't know what to do with no reflow. If I have to tell you which is my experience in the last years, we are now using this kind of system, the MVAST, which is like the stent retriever for neuroradiologists. So it's very similar to the thing that is used for stroke. So basically, and we are participating in studies studying the MVAST, and you see that it's really similar to a stent retriever. You have the flow restoration zone and then a closed distal basket to retrieve material. And you see those are some examples where you use MVAST, so the system, during primary PCI, and you actually are able to retrieve material from the primary PCI. This is the study we are participating in, the Nature trial led by Marco Valgimigli, who is a close friend of us. So the idea is to randomize patients to this use of with STEMI and obviously high thrombus burden, to either MVAST or standard of care, that is basically nothing, and to see from either the troponin and cardiac magnetic resonance if we are able to reduce microvascular obstruction. We have finished the enrollment now, so we will see the result. Just to show you a case. This is a case of, as you see, an anterior MI. You have also disease on the right coronary, proximal part of the right coronary artery. And you have the culprit lesion in the proximal to mid LAD that is occluded. And what you can see is that if you put down this is the MVAST system here in the vessel, and what you see from the last video is that with the MVAST, you are able to restore the flow because you have actually the first part of the system that is for flow restoration. So just by putting down the MVAST, you go from TIMI flow 0 to TIMI flow 3, okay? And then you retrieve the MVAST system, you see here, and actually you use a guideliner or guidezilla in order to reduce the risk of stroke by the embolized material as it is for thrombus aspiration systems. And you can see that you can then go to direct stenting after the treatment of the MVAST. And you see that the final result was very good on this vessel just by using MVAST, direct stenting, and post-dilation of the proximal part of the stent. So this probably in the future, I don't know, 2040, but something like that, can be something useful to reduce the incidence of no reflow, we will see. But then, okay, we treated the culprit lesion, so we just treated the culprit lesion on the LAD in the patient we were dealing with just before. But what to do on the non-culprit lesion? Do we have to treat the non-culprit lesion? When do we have to treat the culprit lesion? How do we have to treat the culprit lesion? Is it necessary to perform another exam, another evaluation? So what do the guidelines say about that? The first point of the guidelines is in STEMI patient that complete revascularization is indicated with class 1, and this has to be done either during the index procedure or within 45 days. This is the indications of the guidelines. If we have a look, then it's the same, and this is another important point of the guidelines is that PCI on non-culprit lesion should be based on angiographic severity, because this is actually what has been done in the complete trial. That is the biggest trial that was performed comparing culprit-only treatment to complete revascularization. So what do the guidelines say? You have to perform complete revasc. You can decide whether to do it immediately or within 45 days, and you should base your judgment on angiography alone. Is it the way to go? I don't know. We will discuss about it in the next 5 minutes. As for the need to have complete revascularization, we have no doubt about it. We have to achieve complete revascularization. This is the analysis of all the trials published that was presented at the last American Heart and published on the Lancet simultaneously. These are all the studies that were included, so from the complete to the FIRE trial. And the main result was that if you combine all these studies, you have a highly significant reduction of cardiovascular death related to complete revascularization. So there is actually no doubt that we have to perform complete revascularization. The cardiovascular death reduction was consistent also if we look at all-cause death, so significant reduction in all-cause death with a median follow-up of 3 years. So this is actually something that is now clear, and we should not go again to treat only culprit lesion. And what about the timing of achieving complete revascularization? You know that we have 2 randomized clinical trials comparing immediate complete revascularization, so complete revascularization within primary PCI, with stage complete revascularization, meaning something happening at 30 or 45 days, the BioVasc and the Multistars, and you see that in both trials, immediate complete revascularization was superior, so was better to staged complete revascularization. So we should say you have to perform immediate complete revascularization. I'm not convinced about that. I will try to convince you in the next 5 minutes. Why? Because if we follow the guidelines, so we perform complete revascularization just based on angiography, what we will do is to overtreat around 50% of lesions. Why? This is the complete trials QCA sub-study. So I remind you, in the complete trial, we performed randomization of culprit versus complete treatment. In complete, actually, if the lesion was in between 50 and 70%, FFR should have been performed, but nobody did it because all the lesions were classified as 71%, so that you can perform PCI without physiology. But then, what happened is that when they perform as a core lab, the QCA analysis, QCA is not something that we use to stratify prognosis of the lesion because it's not perfect, but still it was far better than the eye of the operator, because if you divide the lesions between QCA more than 60% stenosis and less than 60%, what you see is that all the difference between complete and culprit only was in the lesion with higher stenosis. If you have a look at those with less than 60%, PCI was not useful because it was the same to leave them alone or to treat them. So my point is, okay, if we follow the guidelines, so we stent all that we see, we will overtreat at least 50% of the lesion, because in the complete trial, we are talking about 1,300 patients. So it's not a small portion of the patient enrolled in the study. And in this portion of the patient, PCI was not useful at all. So all the benefit was coming from this part of the population. So I don't know if angiography is the best way to decide how to treat patients. Why? Also because, as Yoshi said before, in the next years we will have more and more older patients coming for MI, and as you know, the higher is the age of the patient, the worse is the prognosis related to complications, especially periprocedural MI and acute kidney injury followed by due to contrast utilization. So again, the idea of physiology is exactly to avoid PCI of non-flow limiting lesions. So exactly to reduce the treatment of unnecessary lesions. And if we go back to BioVasc and Multistars, all the difference between the two arms was in type 4, was in periprocedural MI. Because if we remove and we look only at type 1 MI, so we remove the 4A, that is the periprocedural MI, and you see that there was actually no difference between immediate and delayed PCI. Why? Because obviously, type 4 MI, during primary PCI, you cannot detect periprocedural MI because you have a huge movement of troponin related to MI. So if you have a periprocedural MI, you can actually not perform the diagnosis. So all the difference was that after 45 days, if you have a periprocedural MI, you can actually measure it. So it was I would say a bias difference. And the same was for, if you remove the 4A MI, you see that again, also in the BioVasc, you have no difference among the two arms. So I would say that this difference was kind of, related to the fact that you cannot perform diagnosis of periprocedural MI in the context of primary PCI. And if you have a look, all the difference in events among the two arms was in the time between the primary PCI and the stage procedure, because the median time to stage procedure was 15 days in the BioVasc, and you see that the difference was actually in the first 15 days, and in the Multistar was 37 days, and you see again that the difference was in the time going from the primary PCI or from the first procedure to the second one. So what is my point is that if you perform in-hospital revascularization, you will solve basically the issue. And this is has been done as a meta-analysis where they divided the patient of the previous studies with immediate PCI staged in hospital or out of hospital, so at least 1 month before, and you see that in hospital was actually similar to immediate PCI. Why is that? Because if you perform it after 2 or 3 days, you won't have any event in the meantime, so it will be good as immediate PCI. So what I do in my clinical practice is I try to obtain complete revasc within the index hospitalization, but not during primary PCI. Why? Because this is possible, again, if you have a look at the BioVasc and multistars, because they had simple lesions and single non-culprit lesions. So the syntax score of the lesion was very low in 90% of the cases, and they had only one non-culprit. So obviously, if you have a pretty straightforward single non-culprit lesion and then primary PCI was actually very smooth, you can do it also during primary PCI. But I won't say that you have to perform complete revasc in all the cases during primary PCI. Also because this doesn't enable you to use, I think, the most important tools we have in our armamentarium nowadays, because if you have a look at the BioVasc and the multistars, they didn't use either physiology or imaging, because obviously during primary PCI it's very hard to have a high penetration of those tools. And if you have a look at the guidelines says that you don't have to perform invasive physiology with wire during primary PCI. Why? Because we have the Flower MI study in which angiography-guided PCI, so just based on angiography, and FFR-guided PCI, where actually there was a comparison between those two strategies, and the result was negative. So we don't have any advantage related to the use of FFR. But you have to assess that in the Flower MI study, FFR was not performed during primary PCI, but during a second procedure. So you actually perform another procedure just to perform a negative FFR, because almost 50% of the FFR were negative. And this is actually why the guidelines say that invasive epicardial functional assessment is not recommended during index procedure. What we have seen with the FIRE trial, so the trial that we did in older patient with MI and multivessel disease using physiology, because we wanted to reduce the number of unnecessary treatment in older patients. So we used actually physiology to indicate the treatment of non-culprit lesion, is that if you have a look at the two different presentations, because we included both STEMI and non-STEMI patients, you see that the benefit is consistent across the clinical presentation. So in STEMI patient, physiology was as useful as it was in a non-STEMI patient. So this is actually our experience. And when we performed the offline analysis of the angio-derived FFR system, so a reconstruction of physiology based on angiography, in the culprit-only arm, so in patients that were not treated, we were able actually to stratify very well the prognosis of those patients, as you can see here, because you see that positive QFR, so less or equal to 0.80, was associated with a far higher rate of voice if compared to negative QFR. So the ability of this technology to stratify prognosis is real, and actually this is the reason why we performed another trial on the subject that will be presented at the incoming European Society of Cardiology Congress, that is the AIR STEMI trial, where we actually randomized 1,800 patients to angiography-guided complete revascularization or physiology based on angio-derived FFR. Why did we use angio-derived FFR? Because actually this is, I think, the setting where you can have the most benefit from angio-derived FFR system, because you use the angiographic projections you acquire during primary PCI, so you don't have to perform another procedure. And if the evaluation is negative, the patient doesn't have to come back to the cath lab, so it's done just with the primary PCI. And if it's positive, what you can do is to use the pullback curve of physiology to perform a procedural planning. So you already know how and where to treat the patient beforehand when the patient comes back to the cath lab. And the last point is that obviously the issue of physiology in the setting of acute MI is microcirculation. So you can have impairment of microcirculation related to the myocardial infarction. Whereas with the angio-derived FFR system, the impact of microcirculation on the evaluation is lower. So probably it could be the solution, at least in our opinion. We will see with the results of this study if this is the case or not. So if we conclude the management of non-culprit lesion, we can say that yes, you have to achieve complete revascularization. Is it based on physiology or angiography? I don't know. We will see in a couple of years. My opinion is that angio-derived FFR system could be a very good solution, because if negative, you don't have to stage a procedure. If positive, you can plan your PCI and optimize based on the pullback of physiology. So if I have 5 minutes more, I just am going to finish with the 2 things about post-PCI management. The first point is how to deal with DAPT. This is a very important change in the management of the patient, because when we are dealing with an MI, we were used to decide the treatment of DAPT based on the pathology of presentation. So MI patient always have to go through a long DAPT. Right now, the paradigm has shifted. So the first thing we have to ask ourselves is the patient at high bleeding risk or not? If yes, then the patient should go through short DAPT, so 1 month DAPT, no more than that. If the patient is not a high bleeding risk, then we can go through longer DAPT. This is very clear from the guidelines. I just go to the sub-study of the FIRE trial, where we also performed an analysis on HBR patient. This has been published on JAMA Cardiology. And you can see we divided the FIRE trial patient according to high bleeding or risk or not. And you see that, first point, high bleeding risk patients are associated with a worse outcome, obviously, if compared to non-high bleeding risk patient. And we suggested to the investigator to perform a short DAPT regimen in HBR patient, and this was performed in around 60% of HBR patient. And you see that the primary outcome, according to the DAPT strategy, was very similar, but you had obviously far less bleedings if you are able to reduce DAPT duration in patient with MI, multivessel disease, and high bleeding risk. So this is again the demonstration that in high bleeding risk patient, irrespectively from the clinical presentation, the number of vessel diseased, you have to go with a short DAPT regimen. Last point, last minute, what to do about post-discharge. So what are the suggestions of the guidelines about post-discharge? Obviously, they suggest to go through supervised multidisciplinary exercise-based cardiac rehabilitation. This is 1A indication, but we know that it's not so easy to be able to have all our patients going to such kind of rehabilitation sessions. So what we did last year was to try to evaluate a new way to perform cardiac rehabilitation. That is a new intervention that we performed in older MI patient treated with the PCI. And we actually stratified patient with SPPB. SPPB is a short physical performance battery, so we wanted to have those patients actually not too bad and not too good in terms of frailty. So we performed SPPB at the time of the enrollment. If SPPB was in the middle, then we randomized patient to either this new multi-domain rehabilitation or just health education. And the intervention was simple because obviously we tried to control the risk factor, to have diet counseling, but the most important part is the exercise training. We had some supervised sessions in the first months, but then the most important part was to explain to the patient how to perform tailored home-based exercise that were very simple, you know, from the chair or, you know, just to have some kind of very simple movement, not to go, you know, to the marathon, okay? 20 minutes, 3 or 5 days a week. And then what we have seen as a result is that the first point is that the compliance was good, because at the end of the study, more than 70% of the patients were actually still doing their routine exercise 5 times a week. And if you look at the primary endpoint, it was death or heart failure hospitalization, you see that we were able actually to reduce it by more than 40%. And this was related mostly to the reduction of heart failure hospitalization or visits. This was presented at the AC and published on the New England Journal of Medicine. So to conclude, what are my points regarding MI? Primary PCI, treat the culprit lesion as soon as you can. If you can, try to reduce the occurrence of no reflow. For multivessel disease, try to achieve complete revasc within index hospitalization. For DAPT, remember to ask yourself if your patient is at high bleeding risk, and try always to help your patient to perform some physical activity after the discharge. Thank you very much.
Thank you for your excellent talk. Can we keep the last line on the screen? Because that is the important conclusion. And I'm the believer of the thrombectomy, so I am looking forward to the study of the NVEST, the device. So maybe previously we didn't do the effective or adequate thrombectomy by the aspiration catheter, and we can use the guide extension catheter to reduce the embolism, embolic complication. And I think we all follow the guideline and the complete revascularization, and I think the hospitalization is a good idea, because we can take some rest in the early morning, because we don't want to work out in the midnight. And so how about the vulnerability? In the setting of the acute coronary syndrome patient, so maybe the non-corporate lesion is still the vulnerable plaque. So even we use the physiology guide, so can we prevent that the minor, maybe the minority of the event?
Yes, that's a very good point. What we are seeing with the physiology is that vulnerability is associated with the delta FFR or QFR at the level of the plaque. And this is related to the fact that these points are the point where the flow is diverted and it's not linear, okay? So you see a higher delta FFR. There are beautiful studies. We perform a sub-study on the FIRE trial where we perform both IVUS NIRS, OCT, and physiology, and also Carlos Collet has performed another study beautifully showing that if you have a high delta at the level of the lesion, this is highly associated with vulnerability of the plaque. I don't know which is the best treatment for vulnerable plaque right now, because yes, we have the PREVENT, but in the PREVENT we actually prevented the ischemia-driven revascularization, so we did not prevent any MI. So I don't know if PCI is the way to go, or we have just to go very heavily with drugs. We will see, but physiology could be another way to estimate the vulnerability of the plaque.
Okay, thank you for the explanation. And the high bleeding risk patient is also an important issue. So what is the bleeding score do you frequently used?
Yes, we use the ARC-HBR classification, so the one from Academic Research Consortium, so with major and minor criteria. In the FIRE trial, actually more than 70% of the patients were at high bleeding risk because we have the age as an inclusion criteria, and for ARC-HBR, age more than 75 is a minor criteria. So all the patients had the minor criteria. In order to be at high bleeding risk for ARC-HBR, you have to either have 2 minor criteria or 1 major. So most of our patients were actually at high bleeding risk.
Okay, thank you. And I think the rehabilitation is very important because we have the cardiac rehab program in the heart failure patient, but not all the patient of the myocardial infarction. So maybe we can follow the SP, yeah,
SPVB,
SPVB,
yes.
yeah, to risk stratification of the patients and send them to the cardiac rehab.
Yes, at the beginning we had the fear that the older patient with the MI could not have been feasible for this kind of program, but in the end we had a very, very positive feedback. So because also you have to tailor the activity to the patient you have to deal with, because older patient with MI obviously will want to run, want to go jogging, but they will perform the exercise needed for improving their prognosis.
Yes, thank you. And our hospital just have collected some data of the supersaturated oxygen for the myocardial infarction to, like you said, the microvascular obstruction to reduce the infarct size. And also we have some cardiac rehabilitation program that, just like ASU, the home-based rehabilitation program, I think is the way to go, and the remote patient monitoring at home. So I think
it's the most effective way to achieve a good rehabilitation of the patients.
Yeah, thank you. So any questions? Jason, show your English.
Thank you, Dr. Simone, for your excellent talk. And I do have a question regarding the topic you talk about, because during the STEMI patient, during the index PCI, we often have complex scenario, which patient may have multi-organ failure, cardiogenic shock, or all kinds of situation. What's your idea about the timing of mechanical support, and what's your experience on it?
Yeah, that's a very good point. So what we have seen actually from the studies is that if you unload too late, then you actually lose all the benefit of unloading. So unfortunately in our institution we don't have many possibility to perform unloading, because we are the other way around if compared to you. So we have the possibility to use Impella but not ECMO, because it's not possible to perform ECMO in our institution. Our experience is that if you correctly diagnose the patient as an impending shock or at the very first phases of the shock and not too late, then you will have a very good results if you perform unloading and primary PCI. Obviously, for the sake of time, I didn't mention what the guideline says, but the guideline says to treat the culprit, obviously, only the culprit lesion and during the first phase of the shock, and then to assess, obviously, neurologically the patient before deciding what to do on the other lesions. But this is actually our experience. What's your experience in your center?
On behalf of the heart team here, we have some experience on immediate unload, but the truth is when it happens in the daytime or it happens at night during the duty shift, the labor, the manpower is very different. Yeah. So the setting and the outcome may be a little bit affected by the possibility of timing. Yeah,
absolutely.
Yeah, because the ECMO is reimbursed in Taiwan, but not the Impella. So we have the lots of experience of the ECMO and even the lava ECMO to unload the left ventricle. So we think it's the way to go, but the evidence is not enough because it shows the quickly resolution of the lung edema, but not the total mortality because these patients are very sick. So I think we have the good scientific session today, and thank Professor Simone again.
Thank you. Thank you for being here.
And we have a little gift for you.
Thank you so much. Thank you. It's a pleasure. Thank you. Thank you so much. Thank you again.